Hi, everyone. Welcome. We'll just give another couple of minutes before we get started. Hi, everybody. My name is Joe Ross. I'm a physician and health services researcher and one of the co-directors of the Yale-Mayo Clinic Center of Excellence in Regulatory Science and Innovation, or CIRSE. I want to welcome everybody to the quarterly CIRSE lecture. It's really a great pleasure of mine to introduce Molly Jeffery, who's the co-director of our CIRSE from the Mayo Clinic. Molly is a health economist and health services researcher who studies how people use healthcare and health insurance. Much of her work involves using databases of administrative data, including health insurance claims, electronic medical record data, and she's particularly interested in the choices patients and physicians make and how they affect both patient and system outcomes, such as health status, costs, and spending. She serves as the scientific director of the Mayo Clinic's Division of Emergency Medicine Research. And today, she's going to be talking about one of the seminal projects within our CIRSE that she has been leading for several years now, the Acute Pain Pathways study. And the title of her presentation is Real-World Data to Assess Variation in Opioid Prescribing and Use for Acute Pain in Diverse Populations. And I will be keeping an eye on the chat and we'll jump in with questions as they come in, but also please raise your hand or feel free to send me a message and I'll turn it over to you, Molly. Thanks for agreeing to present.
Thank you so much for your very kind introduction. And I am really excited to talk about this study today, which has been a huge part of my life since, well, it's been about 2 years now. So I will just start with the funding and disclaimer. So this study is funded by the FDA through the CIRSE program. What I'm going to present today is mine and the team's and does not necessarily represent the official views or an endorsement by the FDA or the US government. So let's start by talking about why we're doing this study. So opioids have been used to treat pain for at least hundreds, if not thousands of years, but there's really surprisingly little high quality evidence that clinicians use when writing prescriptions, and especially when they're writing prescriptions to treat short-term or acute pain. When I first started studying opioids, I was working with a general surgeon on a paper. And when we were looking at the data, I said to him, so how many days of opioids do people actually need after their surgeries? And his answer was that we really don't know. There's just very limited high quality evidence that tells us how pain progresses for people and how it resolves and what people use to treat their pain. And we see that uncertainty in the really wide variation in post-surgery prescribing that we've documented in many different studies, including this one that I have a little snapshot of here with the citation there. And this variation is not explained by observed patient differences. So we just have a patchwork of evidence that covers certain conditions in certain populations, but other conditions and populations are still pretty much a black box. So this study was designed by our team at the CIRSE and our participating sites and the FDA, our subject matter experts at the FDA, to fill in some of those important holes in the evidence base by focusing on populations that are currently underrepresented in the evidence. And that includes people from minoritized racial and ethnic groups, and people living in rural areas. And by focusing on care settings where people often show up with acute pain, but that have been understudied currently. So we set out about 2 years ago to recruit more than 1,500 patients in dental clinics, emergency departments, primary care, and urgent care settings, and then some selected post-surgery settings. We chose sites that serve diverse populations, and we structured the study to make it possible for all kinds of people to participate. So in this talk, I'm going to talk about the study design and approach. I'm going to present some preliminary, and I will underscore preliminary analysis of the survey data that we've collected so far, and leave some time for Q&A at the end. So please feel free to leave questions in the Q&A or make comments in the chat throughout. As Joe mentioned, I'm going to ask him to keep an eye on them because I can't see them, and just interrupt me if there's a timely question that we should address right away. And just as he said, I was trained as a health economist and we interrupt each other all the time. So that is not unexpected. And if you have a question that you need answered right away, please jump in. So we have 3 primary aims for the study and then one kind of key goal. We're recruiting people who have acute pain, which means pain that has lasted in this study. We're defining it as pain that's lasted less than 8 weeks at the time that they're recruited. Everybody we recruit has been offered an opioid prescription for their pain, and they are all opioid naive by self-report, which means we ask them, have you used any opioids in the past 6 months? They don't need to have filled the opioid prescription or plan to use it in order to participate. They just have to be offered it. And in fact, you'll see a fairly substantial proportion of our participants actually don't report using their opioid, at least in the initial days. After they join the study, we follow participants for 6 months, which is a long follow-up period that we are using so that we can learn about pain recurrence and pain progression from acute to chronic pain. And we ask patients about their pain, the participants, both the original condition they were recruited for and any later conditions that develop, and ask them about all the different treatments they use to treat their pain. So that's the first aim. And while this is primarily descriptive, it's extremely important on its own. We also want to look at associations between different patient characteristics and their outcomes. So what characteristics might predict higher severity or longer duration of pain? Who benefits more from different types of pain treatments and so on? And finally, we have several questions that we are asking to better understand how people handle any leftover opioids they might have after their pain resolves. So we know that leftover opioids can be a risk for what is called diversion, which is when someone's prescribed opioid is used in a way that it wasn't intended. It's given to or taken by a family member or friend, for example. And then, as I alluded to earlier, our key goal for this study is to recruit a diverse population across a range of settings to represent people who haven't previously been included in the evidence base. Our approach to that was to select sites across the country who serve diverse populations. So we've included Monument Health in South Dakota, which is a primarily community healthcare center. They have the busiest emergency department in South Dakota. We have Mayo Clinic community hospitals and primary care clinics in Minnesota and Wisconsin, as well as academic emergency departments in Rochester and in Florida. We have primary care and emergency medicine, as well as some post-surgical folks at Yale New Haven Health, emergency medicine at University of Alabama, Birmingham, and Cedars-Sinai in Los Angeles, and post-surgical at UAB. And then we're also recruiting people receiving dental care in 2 different types of settings. One is community clinics across the South Central states through the Dental Practice-Based Research Network based at UAB. And then we're also recruiting people receiving oral surgery for wisdom tooth removal in an academic dental practice in Rochester, Minnesota, that's at Mayo. And these healthcare systems together provide the ability to include 12 states in the study, and then we've highlighted them on this map. If you want to look at this in more detail, it is available in our protocol, which was published in BMJ Open, and the information is there. This study is possible because we're using a personal health information platform called Hugo that allows patients to link their pharmacy and electronic health record portal accounts to share with researchers information about whatever's in there, the medications they fill, the healthcare they receive. And then importantly, Hugo also does survey responses. So this is a visual depiction of what Hugo does. The participants work with study coordinators at the time they enroll to link their portal accounts, so pharmacy, CVS, and Walgreens, EHR portals to Hugo. And then the study gives them a Fitbit activity tracker that gets linked to Hugo. And then we've also developed a schedule of surveys that collect patient-reported outcome measures, and those are sent to patients by email or text, and they're easy to fill out on a mobile device. So that's kind of how they're designed. These are some screenshots from those. From this sort of set of data sources, we're developing an extensive database on both prescription and over-the-counter medication use, any healthcare received lab and imaging tests, clinical encounters, procedures, diagnoses, and then patient-reported outcomes like pain severity and location. And then from the Fitbit, we have daily activity, we have sleep quality, and so on. So the platform really opens up research participation to more people, because once we enroll them, they can do all of their study participation whenever and wherever they have time, right? They never have to return to the healthcare setting for a test or schedule time to, be on the phone with study staff to respond to surveys. The automated collection of data from these portals also reduces the amount of data entry that we're asking participants to do. So we don't have to ask them, did you go see a doctor this week? We can see it from their EHR portal. At the heart of the study is a schedule of surveys that varies for participants based on their own pain and medication use trajectory. So we have surveys at the beginning and end of the study, as well as daily, weekly, monthly surveys, and then a survey that goes out when people stop reporting opioid use. So the initial survey at the beginning of the study collects demographics, information about the pain issue the participant is experiencing and what kind of treatment they've received. We collect some PROMIS measures. So PROMIS is a collection of validated patient-reported outcome measures that address important physical and mental health function. So we're also asking people about pain medication beliefs, for example, how much relief people believe they can get from pain medications. People also receive a daily survey for at least the first 3 days of the study. And then the survey stops when, for 3 surveys in a row, the participant says, I did not experience any pain. So that one only goes out while they're still actively in pain. It is extremely brief. It asks about pain severity, which treatments the person used, including prescription, over-the-counter, and non-pharmaceutical treatments, and then how much pain relief the person got from those treatments. The weekly survey is different for people who are still reporting pain versus those who are not. So when they're in pain, they get the PROMIS measures, so we can see changes over time in things like fatigue, pain interference, anxiety, depression. And then they're asked about how they store their opioids, if they actually have any on hand. When people have not been in pain, so like when they're not receiving the daily survey or when they respond, I did not experience pain, the weekly survey gives an opportunity for them to re-enter that daily survey thing. So we ask, do you have any new pain or recurring pain? And if they report that they do, then we start sending the daily surveys again and asking about their treatment and severity. There we go. Monthly surveys also differ for people in pain versus those not in pain. So when you're not in pain, you get the PROMIS questions. So we get those monthly for people not in pain, weekly for people in pain. And then when they are in pain, the monthly survey asks about how many pills people have left and if they are using opioids, where they got it. So was it from an old prescription? Was it from a new prescription? And so on. And then we also ask about side effects of opioid use using the PODS questionnaire. when people have gone 2 weeks without reporting opioid use, we send them a survey that asks about their opioid use experience. So why they used or stopped using the opioid, whether their pain has resolved, how satisfied they are with their care, whether they've misused their pain medication, and then whether and how they disposed of any extra opioids, or did they hold on to them and why. And then at the end of the study, we ask some of the same questions as that end of opioid use questionnaire, so that we can capture that information either for people who just didn't respond to that or people who never stopped using opioids. And then we ask the promise measures for a last time and get some updated demographic information, including, has their housing status changed? Has their job employment status changed? Has their insurance status changed? Things like that. So these surveys are just an incredibly rich source of information, and you are going to see some of the preliminary analyses using those surveys in a bit. But first, a little recruiting update. So here's the status of the study. As of the end of July, we are closing in on 1,500 patients. We anticipate wrapping up enrollment by the end of the year. Interestingly, the first patient was recruited for the study at Monument Health in South Dakota almost exactly 2 years ago, September 11th, 2020. So the pandemic has affected our recruiting efforts over the entire study timeframe. There were periods for all sites where study coordinators weren't allowed to be there in person, when procedures were halted. So like they stopped doing wisdom tooth removal at Mayo, for example, for a period. So we've had to be flexible throughout the whole study period. At this point, about half of our enrolled sample has come from the emergency department, roughly equal numbers from the other 3 settings. I will say the primary care setting has been the most challenging place to recruit, and this in part explains why there are so few studies of acute pain in primary care. So historically, and still currently, just about most opioid prescriptions are written in primary care. So we have a lot of opioid prescriptions there, but even setting aside the COVID issues, there are some things about the setting that make it really tough to recruit for this study. So first of all, many people, in fact, most people receiving an opioid in primary care are not opioid naive or are receiving an opioid for chronic pain. So they're not eligible for the study. The volume of primary care prescriptions is still really high. So, you do still have a reasonably large number of potentially eligible patients from primary care. But the second thing that's very complicated about recruiting in primary care is that patients tend to be spread out across a large number of prescribers and often a large number of buildings or clinics. So this makes it really tough for the study coordinators to catch patients in person, which was our original plan. We originally planned to enroll everybody in person. So we've had to adjust in a lot of ways over the course of the study, both in response to COVID and as we learn more about how best to reach our population. So most sites have now moved to at least some remote recruiting where a study coordinator calls or emails patients who might be eligible after they've already left the clinic and then enrolls them over the phone or over Zoom. And that has made primary care recruiting much better. So this is just a snapshot of our recruiting at Mayo. This is one of our ED study coordinators making calls to recruit patients and enroll them. She calls people in 7 emergency departments across 3 states every weekday. Most of those are community hospitals. And she makes her calls based on this snapshot of a slicer dicer report that I run every weekday morning that lists every opioid prescription written in our included clinics and EDs in the past 3 days. So then I go through and filter out all the opioids that aren't pain medications. So I take out the cough medicines, I take out the GI preps, I take out buprenorphine that's used to treat opioid use disorder. And then I take out the prescriptions that are part of our end of life protocol. It's the morphine drops. So we aren't bothering people by calling them to potentially enroll them because clearly they don't have acute pain and they're not going to participate. So in addition to the emergency medicine prescriptions, which you see here, there were 80 of them in this 3-day period. You can also see we have primary care prescriptions, so family medicine, community internal medicine, and then a couple at an express or urgent care. We have another study coordinator who does that recruiting. So we have just been at Mayo incredibly fortunate to have very skilled and very patient study coordinators who really stepped up and kind of figured out how to do this thing that during the pandemic that we have never had to do before. We're enrolling people for a study like this online. It was not our original plan. And they have just been spectacular, as have all of the site study coordinators at all the sites who've been really creative at reaching patients. At this point, we are exceeding.
Molly?
Yes, go ahead.
Sorry to interrupt. I think there's one Q&A question that would be good to address now, which is, because now that you've talked about enrollment, which is somebody asked, how do patients get consented to participate? Maybe just in a little bit more detail. And does the system continue to track and collect data after the study is completed?
Oh, great questions. So, so we consent people online, and the consent. So when they sign up for Hugo, and I have never done this myself, so I'm describing it the way I have been told it works. And apologies for any inaccuracies. But essentially, what happens is they sign up for a Hugo account while they're on the phone with the coordinator. And then it presents to them their site-specific consent document. They go through it with the study coordinator while they're on the phone, or for the small number that are in person, they go through it with the study coordinator in person, and then they sign on Hugo. So all of that is tracked within Hugo and presented to them within Hugo, and then they can access it through their Hugo account, or I think we also can email it to them, their signed document. So that's the consenting form. And then the other question was whether it continues to track their information after the study. So if they keep their Hugo account, so Hugo is not just us, right? There are other studies and people can participate in other studies through Hugo. So patients have control over who can see their data and when. So they can shut that off at any time if they decide they no longer want to participate, or if they decide they no longer want to share their data, they can shut that off and then no further information flows through.
Great. Thanks, Molly. There's another question about missing data, but I think you'll get to it when you're talking about the actual analysis. But then
maybe not. Go ahead and ask.
Well, first I'll ask from Caitlin Brown. She asks, are you including tramadol in your recruitment eligibility criteria?
Yes, we are. Yep.
Okay. And then the missing data question is, how did you treat the daily, weekly, monthly missing data on the surveys, and what's the level of missingness? So I think you will address some of that.
So I have a slide on missingness that I can go to at the end, but I think as we go through the analyses, it may become clear. We know that there's missingness. We've planned for some missingness in asking the same types of questions multiple times. So if we miss one monthly from somebody, but we have the one before and the one after, then we kind of know what's going on with their promise measures a little bit. And then in other ways, we just need to be really thoughtful about who is presented each question and therefore who goes in each denominator. So I have tried throughout to be very clear about who's in the denominator for every analysis. But we just have to be really thoughtful about it. So at some point when we're doing kind of multivariable analyses and we want to try to look at associations, we will probably do some fancy stuff with imputing, multiple imputation and things like that. But at this point, these are very simple descriptive analyses. So I hope that helps. So for this one, for this particular analysis, we're looking at everybody who enrolled. And our goal, as I said earlier, is to have at least 20% of our participants self-identify as a minoritized race or ethnicity group. So this is showing people who selected, for many people are able, so there were some differences in surveys, but many people are able to select multiple races. So if people selected multiple races or wrote in multiple races, they show up in this multiple times, as well as if they selected Hispanic, Latino ethnicity separately from race. So the goal was 20%. Currently, 35% of our participants self-identify in one of these groups. And that's just been a natural result from where we're recruiting. We're not using any kind of enrollment quotas at this point and won't need to. So this is a pretty young group across all of our settings. 8% are 65 or older. So it's partially driven by the inpatient population. That's the post-surgery people. which is mostly people who've had a cesarean delivery. So obviously that's a younger group. Our study does focus on adults aged 18 and over, but we included a small group of adolescents aged 15 to 17. So that's here in the dental group who are having their wisdom teeth out. And that was just to have some information about adolescents using opioids for a single condition so that we could do some analysis, even though it won't be a large number of people. It'll be a fairly similar group of people in terms of the pain that they're experiencing. More than 60% of our population is female. Some of that is driven by the cesarean deliveries, as I said, but across all of the settings, we are recruiting more female than male participants. And this is a first take at categorizing the types of pain that people are experiencing. So we created this classification. So the way that we find out why people what kind of pain they have is just we ask them to tell us, why did you come to the doctor? What are you essentially, why did you come to the doctor or the clinic? And so we went through and we reviewed every free text response for that. We had 2 physicians. We sat on a Zoom call. We went through every single response together and then created groups that make clinical sense to these clinicians in terms of the type of opioid prescription that would be written for that condition. So our most common indication was dental pain, which is primarily driven by the light green is people recruited in dental. But we also see dental in the emergency department, that's this kind of turquoise, and in primary care, which is blue. We also saw a lot of musculoskeletal pain and trauma and injury in the ED and the primary care settings. We have a large number of ED and primary care patients here who are not currently classified. We will be using their electronic health record data to help classify them. But these are primarily people who either didn't respond to that question, asking what brought them in, or whose response was unhelpful. So the responses to that question are amazing. They're fascinating. They range from fell off a cliff to, somebody will say just arm, or somebody will say pain. So it doesn't really help us sort of classify it into one of these categories. I will say that we can recategorize these any way we want because these are free text. And so as we progress through analyzing the data, we can definitely change those categories.
Molly,
go ahead.
Can I interrupt again? I think there's a good question that would be good for you to answer live, which is that somebody asked, I see that there are a disproportionate number of white participants. Are minorities offered participation at a level commensurate with the demographic occurrence within the US and just choose not to participate? Or is this representative of health insurance care disparities?
So we are not limiting by what kind of health insurance we have. So we do have people who don't have health insurance, although, it's not incredibly common. So it's limited by who accepted our offer. So I will say, like for Yale New Haven Health, I have been told that New Haven matches US demographics exactly on racial and ethnic groups. We wanted to include rural folks, so we have the sort of Minnesota and Wisconsin people, who are more disproportionately white compared to the rest of the country. But Cedars-Sinai has more Hispanic Latino people, and actually more African American Black people, and so does UAB. So we're offering it to the people who show up on our reports, show up in our settings and things like that. But people do decline for many different reasons. We haven't analyzed the race ethnicity of people who declined to see what that looks like compared to the population that accepted. That's a possibility. But yeah.
There's one other question that I couldn't type out the answer because I wasn't sure. They asked whether you're using static or cat promise.
Oh, we're using static.
Okay.
So yeah, we didn't have a way to integrate the cat. I think it goes through an API. We didn't have a way to integrate that into Hugo, so we're asking static. I will say though, we did drop a couple of questions, like from the sleep one. I think we dropped a question where it was almost identical to another question. So we tried to limit the the respondent burden, but essentially our promise measures are based on the promise 29. I really wanted to do the CAT. That would have been amazing, but no. But we are scoring it using the one that allows for missing. So we're scoring it appropriately and taking into account when people don't respond to different questions. So we talked about who we've recruited. Let's talk about some of the preliminary analyses of this is all coming from the survey data, but asking people directly about their experience, right? So we'll start by talking a little bit about pain severity and then time to pain resolution. So in the very first survey, in the enrollment survey, we ask people to rate their pain at the time of their healthcare visit where they received the opioid prescription. So this plot includes 1 dot per person at their pain rating. And then I've overlaid the median is the middle, and then the quartiles here, and the dots are what's called jittered, so they're moved a little bit, just so you can see how many people are in each location. So like this dot, these people all responded 10, these people all responded 9, even though they're offset a little bit. So what I see in this is pain severity at the time of the visit was fairly different across the recruitment settings. So ED patients were much more tightly clustered at the most severe pain ratings than the other settings. And the dental patients were more likely to report lower pain. We don't really know why. It could be because their pain was well controlled at the time of the treatment, or that they weren't in any pain before they went in for treatment. Like for third molars, you might not be in any pain, right? They just need to come out. And when you leave, you might be feeling pretty okay. So the prescription might be intended for pain in the coming days, but it will be interesting to look at how, whether some of those folks who start out with really low pain, including the zero pain folks, later experience more pain in subsequent days. And for each of these, this is everybody who responded to this question on the enrollment survey, and I've got the ends for each setting. After that first visit, where we do see a lot of very high pain, we see the pain ratings coming down pretty quickly in the first few days of the study. So when patients stop reporting that they're in pain, they stop receiving the daily survey after 3 surveys in a row with zero pain. So the pain rating is never going to go down to 0, but it is quite high right in the first day or so, and then comes down pretty quickly in the first 2 weeks. This bottom panel here is telling you how many surveys contribute to each data point, just so you can get a sense of how many people are still responding to the daily or have started again, how many people responded to the daily survey at these sort of later dates. This is the first 90 days of participation. One of the really important questions we want to answer is how long people continue to be in pain. So here we're looking at one measure of time to pain resolution. And what that is it requires 3 daily surveys in a row with no pain reported. And the date of resolved pain is the first of those. So if somebody reports no pain on Monday, Tuesday, and Thursday, the date of resolved pain is Monday. And this plot is limited to people whose pain resolved, and that resolved in the first 50 days of the study, just so you can actually see what's going on. If we include too much time for a resolution, you just lose any of the detail. So both dental and emergency department participants had a large number of participants whose pain resolves in the first week. The ED, the inpatient, and the primary care, though, all have at least 25% of those whose pain resolved continue to have pain 3 weeks out from their visit. So they're continuing to experience that initial pain 3 weeks out. We also directly ask people in the end of study survey whether their pain resolved. And the way we ask it is, do you feel that your pain and related health issues are completely resolved? And among those who completed the study, so we still have many people who are still in the process, they haven't reached the end of their 6-month period. So among people who have completed the study and who have responded to the final survey, we see a large difference between the dental setting here and all of the others. So 80% of the dental patients report complete pain resolution versus, 39 to 54% of the patients in other settings. And notably, among this, somewhat self-selected population, but it is still notable, among this population, 20 to 30% of those seen in the non-dental settings report their pain is not at all resolved 6 months out from their initial prescription. So, we need to keep in mind that some people whose pain went away right away might not have hung on to the end of the study. They might have gotten sick of responding to our surveys or whatever. So, and we can look at that in the future and look to see if people whose early pain was low do drop out. But so, it is a somewhat selected group, but it does suggest that there's a really substantial risk of continued pain in this population, as much as 6 months out. So in addition to asking about their pain, what we're calling their pain trajectory, which is, the severity and how long it persists, we also ask a lot of detailed questions about what kinds of treatment people use, and then importantly, how much relief they get from those treatments. So I'm going to present some of those now. So this table is just looking at what treatments people used in the first 10 days of the study. And it only includes 1,212 participants who reported using at least one treatment in the first 10 days of participation. That treatment could be an opioid, it could be a non-opioid medication, or it could be non-pharmaceutical, like resting or staying home. So they just had to report at least one treatment form in their first 10 days to show up in the denominator. And then this is just a partial list of all the treatments that we asked about. I just focused on the most commonly used treatments. There's a lot going on in the table, so I've kind of blanked it out, and I'll reveal it a bit at a time to just kind of walk through it. So we looked at the treatments that they reported, and that could either come from the enrollment survey or it could come from daily surveys. And we tabulated the proportion using the treatment at least once in the first 10 days, and it includes both cases where people actually checked a box, like we said, did you use hydrocodone, and they could just check a box, and a complete review of all of the write-in responses. So we also allowed people to say other, and we went through and reviewed every single response that people wrote in as free text and interpreted them as best we could. So in this table, we've got the 3 most common opioids, the 2 major over-the-counter meds, acetaminophen or Tylenol, and ibuprofen or Advil, and then just a few of the most common non-pharmaceutical treatments that people reported. And that category, supportive measures, is one that we put together, and it includes ice or heat, including hot or cold baths, things like that, compression or like a brace, elevating the injured part, massage, and then a couple of people responded that they used TENS. So the opioids. The counts are the number of people reporting using the treatment at least once in the first 10 days. And then, like I said, the denominator for that percent right here is the number of people reporting using at least one treatment in the first 10 days. So that's down here. So anyone who never reported a treatment is excluded, and anybody who reported they used no treatment, like they responded, but they didn't say that they said they did not use a treatment, those people are excluded from this denominator. Across the settings, what I think is really interesting here is which opioid was used varied substantially. So hydrocodone is most common in the ED, oxycodone most common in the inpatient setting. They were used roughly equally in the dental setting. And I will just say, I don't know how many people on here are not fully steeped in opioid lore or don't prescribe it themselves. So I'm just going to tell you the general perception that I hear from people who write prescriptions, and I'm not saying this is accurate, I'm just telling you this is what I hear. So what I hear is that tramadol, people think of it as being kind of an opioid light. It's maybe not a true opioid. Just to be clear, it is a true opioid, but that is often the perception that you hear. We hear that hydrocodone is considered a weaker opioid and oxycodone is a stronger opioid. And the other thing that feeds into this is that hydrocodone is only available in combination with acetaminophen, whereas oxycodone, you can commonly get it either on its own or with acetaminophen. So that might drive some of this difference in hydrocodone versus oxycodone. But I think, if you talk to a lot of prescribers, they would say, I give hydrocodone, it's a little bit weaker. I give oxycodone when people have really strong pain. And I'm not saying this is accurate, this is true, but I do hear that people say, and I give tramadol to, a frail person, an older person, somebody who's worried about opioid use. So we see tramadol is most common in primary care. There's a little bit in inpatient, a little bit in the ED, and almost none in dental. And so the other thing to look at on this one is this one or more opioids. So remember, everybody in this study was offered an opioid prescription, whether or not they accepted it or filled it. So it's really interesting to me that 61% of the dental participants who reported using a treatment never reported using an opioid. And 70 to 80% of the participants in the other settings reported using an opioid in those days, right? So 39% of the dental folks never used an opioid, even though they definitely had a prescription for one or were offered a prescription for one in those first 10 days. Many more participants reported using acetaminophen or Tylenol and ibuprofen, more than 90% of the dental and inpatient participants, and more than 80% of the ED and primary care. And what's interesting here, so this is any opioid, and they used either acetaminophen or ibuprofen. So most people who reported using an opioid, if you compare this one to this one, also used either acetaminophen or ibuprofen in those first 10 days. So a lot of use of both. In terms of the non-pharmaceutical, it was very common for people to report that they rested or stayed home to manage their pain. Many people reported these supportive measures. And I will say that this was one of the most interesting sets of free text responses to classify. I know Joe looked at them, Rebecca Hackman looked at them, Fernanda looked at them. We had a lot of people write in, I think this is very creative, or maybe they were told to do this, that they used distraction to manage their pain. So reporting, they played video games, they watched videos, they reached out to friends. I will also say there were some really heart-wrenching responses to this question. So people saying nothing helped. People saying, they managed their pain by crying. And, I will also say a participant after my own heart reported using Dairy Queen to treat their pain, right? So we got a lot of really interesting responses, really creative responses, and it was fascinating to read. So what was the success of these different treatments? In these daily surveys, we ask with how much relief they have from any treatments they used on a scale from 0 to 100% relief. So we compare the amount of relief achieved on days when people, in the left column is people who used an opioid, any opioid, and they could have used also non-opioids or non-pharma, but they used any opioid, versus the middle column is people who did not use an opioid, but used non-opioid pain meds. And they could also have used the non-pharmaceutical. And then the last column is people who did not use any medications, they used non-pharmaceutical only. So this is the median pain relief on a day with any opioid versus non-opioid pain meds versus non-pharma only. So lower pain relief when you use only non-pharm, probably not surprising. But the upper quartile was the same across all of them. And it was much more common for people who used non-pharm only to report that they did not achieve much relief at all. We did use a fixed effects Poisson regression and tested for the difference in pain relief between opioid and non-opioid pain med days. And pain relief was non-statistically significantly 1.7% higher on opioid days. So on opioid days, people had roughly 2% more pain relief, but it was not statistically significant. And then comparing non-pharma days to non-opioid pain days, pain relief was 13% lower. And that was statistically significant.
Molly, if I could jump in, I know you're going through a lot of data, but there's some interesting questions.
Absolutely.
One from Tamara Meyer asks, how do you think participants understood the additional non-opioids question if they were using an oxycodone or hydrocodone product in combination with acetaminophen?
Yep.
And I'll ask another question after that.
We did not ask them to clarify that. So what we did is we offered them 3 panels of treatments. The first panel is prescription medications, and that included checkboxes for hydrocodone. And then we included, like Vicodin and like other names for it, Norco, whatever. Oxycodone, short acting, oxycodone, long acting, tramadol. And then we had like a bunch of, like muscle relaxants and other NSAIDs and a bunch of other prescription pain meds. And they could check any number of those boxes and then also write in. The next panel was over-the-counter meds. And so there was a Tylenol one for that and an Advil one for that and a bunch of others. And then the non-pharm. So when I make these categories, I look and see, did they report an opioid? Did they report non-opioid pain meds only? We made the decision that if somebody is using hydrocodone, we do not classify it as also being acetaminophen, even though we know they had acetaminophen, in part because you can't always tell, because if people select oxycodone, you don't know if they had the type that has, ibuprofen added or acetaminophen or aspirin or whatever. So just in part because we can't. So it's essentially somebody separately reporting that they use Tylenol. However, if somebody was savvy and knows that hydrocodone has acetaminophen, they may have also checked the acetaminophen on the next table. So it's possible that people reported that. Did that make sense?
Great. Yep.
Okay.
And then another question was data collected, what is the proportion of opioid usage compared to amount prescribed? Are you able to answer that?
We are working on that. So we want that answer to be really good. And so we're working on that, and it will be coming soon, but I'm not reporting it today.
Okay, and one more, and then I'll let you keep going because I know we're running out of time.
No, I'm almost done. It's fine.
Oh, okay. Yep. By pain relief, do you mean reduction in pain intensity or relief, whether pain decreased or not? So that's a subtlety.
Oh, that's interesting. We just asked them, I think it was just how much pain relief did you achieve from the treatments? I'm not sure exactly how we worded it. So I guess we allowed them to interpret that themselves, what that meant.
Okay.
And there were people who said things like, I can't use meds because I work today, or like I can't use meds because they make me sick. So there could be people who are in that non-pharm only who reported, I rested or stayed home, and they didn't use meds for a reason. And so they don't expect the non-pharm thing to work very well. It's just that was what was available to them because they had to work, or because, they haven't found a medication that works for them. So I don't think it's necessarily a sign that like people were trying things and it was failing. It's just, it kind of is what it is for some folks.
Okay, Kayan Zhang asked, is it correct that the pain relief from treatment scale has an increment of 1 on a scale of 0 to 100? It looks like this is a measurement error. I'm
sorry, it was like a vase. So they had a slider and it could stop at each 1 percentage point increment. So that's what these sideways, this is what this histogram is showing. So this is the number, people tended to heap at the 10s, which may have been marked. I think the 10s were marked, but they could leave, they could put the slider wherever they wanted. And so some people did choose, 96% or whatever as just smaller numbers. So there could be measurement error in there for sure, but we did allow them to choose 1 percentage point increments.
And then someone asked about 10s. You mentioned some people use 10s, and they asked whether those patients had better or worse responses than other non-pharma treatments, but I'm not sure that we've gotten that far with the data yet.
There weren't enough people, and the trick about that one is we didn't include it as a structured response. So I would be very reluctant to put a ton of stock in that, because that would just be people who wrote that into their free text response. And it was too few people. There could be other people who were using the 10s for a different pain condition, for example, and just didn't report it because it wasn't for their acute pain. And so they weren't really thinking of it that way. There could be any number of ways that people interpreted that. But it was just to note that we did, in fact, see a couple of people report 10s. I mean, we saw a lot of people who reported things like there's some homeopathic rubs, like topical medications that people use that, we included, if it was homeopathic, we included it in this non-pharm. If it was something like menthol or salsalate or something where there's, it's pharmaceutical, then we included it in the non-opioid pain meds. But So there's a broad variety. There was somebody who reported a pickle and the juice as their treatment. And I had no idea. I was wondering if that was slang for some drug I've never heard of, but it is a thing that people drink pickle juice for pain. So, we heard a lot of different responses. I would not be super comfortable at analyzing a lot of them though, just because there were small numbers and we didn't ask people specifically. And unfortunately I'm kicking myself that we didn't include distraction. We should have included distraction as a checkbox, because it's a well-known, it is a thing, but we just didn't think of it at the time that we were setting up the survey responses. We had a lot of people write it in.
Do you want to finish your slides? There's a couple more questions, but maybe try to get.
This is my last substantive slide. So this is just noting. So, okay, here where we have, pain relief from treatment, and it's pretty similar for opioid versus non-opioid pain med days. Just keep in mind that people tended to take opioids on days when their pain was worse. So in this upper panel here, it's the mean of the patient reported pain by day on days when people reported any pain. So it includes people who responded to a daily survey. They said that they had pain, and it takes the average for that day. And the blue circles are people who took an opioid on the day, and then the gray squares are people who used some other pain medication that was not an opioid. And then this panel down here at the bottom tells you how many surveys on each day contribute to each data point. So the blue one is the opioids. It's transparent, so they're overlaid. So you can see how many people responded to each of these. And you can see, in general, but especially at the beginning of the study, when we expect people will, most people will still have an opioid, the mean reported pain is higher on days when people take an opioid versus days when they don't take an opioid. So the fact that they get similar pain relief, it may be off of a higher base of pain, right? We used fixed effects Poisson regression again to estimate the difference in pain on opioid and then non-opioid. And then we also included this non-pharma only. It included 1,100 people who had at least 2 dates, because it's fixed effects, where they reported using treatment for pain. And pain was 23% higher on the numeric rating scale on days when people used an opioid versus days when they didn't. And it was a fairly tight confidence interval, was 23%. The confidence interval was 19 to 27%. And for non-pharm only compared to other meds that are not opioids, it was, they reported lower pain on those days. It's 18% lower pain on those days. So just a caveat that on the, that the pain relief people have, it may have been off of a different base of pain. And I think Tamara Meyer is the person who asked about that. And so kudos to her for suggesting this analysis, which is a great point. So the last, thing is just to say what we're doing. So we're finishing off enrollment, continuing to work with the survey data, and really digging in now into the EHR and Fitbit data, which is just going to add a lot to what we know about the patients, about the participants and their experience. And I don't want to avoid, I want to make sure everybody has a good chance to see this slide, because this study is the work of literally dozens of people, both at the FDA and at all of our participant sites, who have all gone far above and beyond on a challenging study and during a really challenging time for research. And we would not be here without every single person on this slide. I wish I could have listed all of our site leads and recruitment coordinators and project managers and team members, but there's too many to include them all. But thank you to all of you. And thank you as well to the participants who are really making an amazing contribution to science. I appreciate them so much. I think about them all the time. I have literally read every single free text response that anybody has contributed. And think about those folks. And I think about the people, especially the people who are suffering. And it is really my hope that this study will improve patient care and improve safety for people who are in pain. Please reach out if you have questions. Absolutely. My contact info is there. Would love to hear from you. You can also tweet at me at Molly Jeffery.
Molly, there's a few more questions in the Q&A. It might be easier for you to open it now that the presentation is over and take a look, because I think it'll be more efficient and because there's only a few minutes left.
Yes. So I will just stop sharing. Okay. So let me pull up Q&A. Okay. So
And
the
I've tried
non-farm,
to answer some in the chat. Hopefully I've gotten the answers right.
yeah. So the non-farm participants have the same baseline pain level, right? So that's the thing. So on non-farm days, people did tend to have lower pain reported. So no, I'm not sure what usually for back pain only means. This might be referring to a different question. Did we stratify by baseline pain? Not in our current analyses, but we can. So we could say only among people who reported 8 to 10 on the pain scale for their initial or for their first day. So we have not currently, but we can. Do we have the duration of opioid use? But yeah, so I think I responded to that. So we are going to look at duration of use. It's just we're going to have to pull together information from several different surveys. And I want to make sure that we do this as, carefully and accurately as possible. So we're still working on it. I couldn't get it ready for today, but hopefully by the end of the month, we will have something. And then I see if you want a copy of the presentation, yes, Latoya, I can get that to you. I've sent that to her, to a couple of people. Is there anything in the chat as well? Doesn't look like it. Does anybody have any questions?
Yeah, everything's been in the Q&A. There was one other, which is I think quite people find interesting. How do you classify chronic pain? Does your data look at whether these naive opioid users become chronic users, either from chronic pain or opioid use disorder?
Yeah, so I mean, there's no like single way to classify chronic pain, right? But a lot of times people think of it as pain that lasts 6 months. So because we're following people for 6 months, we should be able to figure that out. I would say in that one that I showed you, where we look at people who responded to the end of study survey, a substantial proportion, I think it was around 20% of the non-dental settings reported that they were still, their original pain condition was not at all managed. And as I said, it is different. It's a different group of people who made it through to the end and finished their end of study survey, but there is a substantial proportion who are there. We can use other measures of it as well. And we can also, so every time they report pain, we ask them where they feel it. And there's like a body map. So we could also look at something like when somebody initially started the survey, they reported pain in their wrist. And then we see that they have chronic pain later and they're reporting pain in their knee. So that's a different condition. We may also be able to tell from the electronic health record what other types of things are contributing. So we have a bunch of different ways that we can kind of get at that chronic pain question. Let's see, suggest using same pain scale across instead of 1 on 10. And so the one that's on 100-point scale is not a pain scale, it's a pain relief scale. So for the pain, every time we ask about pain, we ask the standardized numeric rating scale, which is 0 to 10. And it's the standard in pain measurement to the extent that we can have a standard. And then the pain relief percent is 0 to 100%. Functional outcomes, yes, are going to come later. We have many questions, and we did a preliminary analysis comparing like the promise measures at the beginning and the end. We see a big difference in pain interference, which is one of the scales from the promise 29. So we are seeing what we would expect to see, which is great. And we can do even more on that too, in terms of things like anxiety and depression and functioning as well. So that brings us to 3 o'clock. Thank you all so much for joining today. I really appreciate it. And I appreciated the opportunity to present on this study. Please reach out to me by email or on Twitter if you have more questions or if you have suggestions for analyses. I would love to hear them, and the rest of the team would as well.
Thanks, Molly. And everyone, you can reach out to Latoya if you want a copy of the slides. It's in the chat. Thank you, everyone.
Thanks, everyone. Bye.